Okay, hello and welcome everybody. For those of you who haven't met me, I'm John McClaughlin. I'm the Chief Exec of Response and I'll be co-chairing today's meeting. Andrea, do you want to introduce yourself, and Lila, please? And then.
Hi everybody, it's really lovely to see you. Thank you so much for making the time to be here. So I'm Andrea King, I'm Assistant Director in the mental health team across the South East for NHSE, and I lead on children's mental health across the team.
Good afternoon everybody, lovely to see some old faces. I'm Lila Johansson and I'm the region's Children's Improvement and Delivery Senior Manager, and I work with Andrea.
Thanks. So Andrea will be co-chairing and presenting, and we will have breakout options later where Lila and Andrea will be leading some of the breakout rooms. I think, yeah, just thank you so much for taking the time to join us today. This meeting is probably the result of numerous other forums and meetings that we all attend, where we continually discuss the issues that we're all facing in the CYP world, particularly in terms of the demand and surge that we've seen as a result of the past sort of 18 months. We have, in some of those meetings, we've heard how both commissioners, mental health care trusts, local authorities and third sector have been working together collaboratively to meet the demand. And we realise that there really are some pockets of excellence across the South East and indeed nationally. And we thought it'd be a really good idea to actually try and bring some system leaders together, people who have, shown great initiative and great innovation in terms of meeting the demand and actually setting up services and some very, very innovative services to actually help each other out. And I think, I've worked in the health service, and I've also worked in the third sector for a number of years. And actually seen when the organisations actually collaborate, the results can be quite phenomenal. So I will be talking. Andrea will talk a bit more about sort of the system, about the environment we're operating in, about the demand, and what the key issues are. And then I will talk a little bit about some of the examples I've come across where the third sector are working very closely with statutory organisations to deliver services, both sort of traditional services, new services and new pilots, and are actually putting together some models for services that we hope to deliver in the future. We'll then allow some time for people to raise sort of what some of the key issues that they may have that they would like to sort of raise at this forum. And as I said, that we will go into some breakout rooms to discuss some of the particular questions that hopefully you may have seen already. Our hope is that this starts to generate discussion, that actually it starts to look at some areas of best practice. We also hope that the third sector representatives that are here today will start talking more to the counterparts possibly that they wouldn't normally talk to because of geography, etc., and that we actually can begin to share models and develop services going forward. So please, I think as I say, we're not going to do introduction. If you have a question to ask, if you maybe introduce yourself while you're asking the question, that might be helpful. And I think, Andrea, I'm happy to take up questions during my presentation. I don't know, are you happy as well? So I think it's just use the hand up function within Teams. Richard is very kindly sorting everything out for us in terms of the technical. So if you've got any questions, you've got any issues, please let him know in the chat section. There you go, as we speak. Thank you, Richard. So over to you, Andrea.
Thanks so much, John. It's really lovely to see you all. I'm not going to speak for very long at all. I'm just going to speak for 5 minutes or so on the current position around children's mental health, which is where we're going to focus our time and discussion today. I'm really hoping that this time together might be the first of several conversations that we start to develop together across the South East, where chief executives and leaders in our voluntary community and faith sectors sit with us side by side, and we say, okay, so what can we do? In the virtual room today, we've got our foremost voluntary sector leaders, and we've got our commissioners as well, both from public health in local authorities and social care, also from CCGs, and we've got provider trusts, so mental health trust representatives here today. And this is a chance for us to think together. I don't know if anybody's picked up the news today. I'm just posting this in the chat. NHS Confederation have just released just today the figures of children's mental health need across the country by their estimation. If you click on that link, it will take you through to a really short and succinct media article that summarises that for the children's sector, and it's poignant and kind of really salient reading. What we've seen since COVID began is a significant rise in the number of children with emotional health needs at the lowest level and mental health needs at the highest level. A number of those children just found their experience of lockdown, so being kept at home, isolated from school and friends, an incredibly challenging place to be. For some of our children, they were stuck in home environments that just were damaging for them, felt intolerable to them. And so we've seen a whole range of different emotional and mental health needs emerge for our children and young people from the ages of 0 to 25, so the whole spectrum that we look at together. In the southeast region, we've been particularly badly affected by that level of need. So nationally, we've seen between a 40 and 60% rise last year, and we're going to see the same rise again this year of children needing emotional health support and mental health support. Our southeast figures, so everywhere from Milton Keynes right the way around to Medway and down to the Isle of Wight and back again, have been higher than most other parts of the country. And that's not necessarily a bad thing, yeah? So in some ways that means we're spotting children who need help, and children feel able to say to us, children, young people, adolescents, young adults feel able to say to us, we need some help. That's a good thing. But the demand is rapidly outstripping our supply. So you'll have seen on the slide that Richard was just sharing this kind of graph that's doing this. If we look at specific types of emotional and mental health need, you'll spot some other features there. We've seen an incredibly sharp increase in the number of children and young people, and now adults too, who are presenting with eating disorders or disordered eating. Yeah, so when everything feels out of control around you, one of the things you can control is food, your food intake. Our eating disorder rise has been so significant, and we have had a very large number of children and young people who have needed very specialist care, and a not insignificant number of children who've needed to go into Tier 4, so the most specialist residential treatment. We've had more children than we've had places to put them, so it's been a really tough year, and this is one of our foremost priorities together. In the same year, we've seen more and more children and young people in crisis, needing urgent help, particularly over the weekends and in the evenings, just someone to talk to about how they're feeling. And our hospitals particularly have borne the brunt of a lot of that need for extra help. And so together we've been setting up really quickly 24/7 helplines and so forth, support for our children and young people really, really quickly. We've also spotted that for our children and young people with protected characteristics, life has been much tougher. Our UK society has not been a friendly place, always, for children and young people who find themselves with protected characteristics that set them in a minority position. So our children and young people with learning disabilities and autism have not always had a really easy time of it and have really struggled with their emotional health needs. For some, being at home in lockdown was preferable. For others, it was tough. For our communities with diverse ethnic and cultural heritage, the UK society is not an easy place to be at times. Ditto for our rainbow community, our LGBTQ+ community. The experience of exclusion and othering is increasing in our society. That's hard, and we see the emotional health impact of that all of the time. And at the heavy end, we see that quite starkly. So those are some of the considerations that we've had in mind. And we simply don't have the reach, we don't have the workforce, we don't have the capacity in our core statutory services to respond to all of this. And I know this isn't new news for anybody in this room. What we've been encouraging our commissioning colleagues who've joined us in great numbers today to think about is, what's the potential to really invest in the voluntary and community sector? Not at a specialist level of mental health intervention, but in supporting communities, non-stigmatising support in communities that our children and families feel they can trust, a place they feel they can go and ask for help. We've got a number of colleagues in the room who are providing those kinds of support services. We also know that it's easier sometimes to attract people to work either as a volunteer or as a paid member of staff in a charity, community or a faith sector environment than it can be in our core statutory services. After time, and we'll hear some examples of this in a minute, we've seen some of this workforce in our voluntary sector have the potential to grow and expand with the support of our mental health services or other statutory partners to become a supportive or the next generation of workers in our wider sector. So these are some of the things we wanted to explore with you today. In the context of what we might do together, we're going to look at what already works. So some examples in the South East of where we've designed really agile support structures within voluntary sector leadership that our children and people can rely upon, that stay around, that provide that trusted relationship for long periods of time. We're going to look at how was the training and supervision of that enabled? How was medium-term funding offered to provide some security for voluntary and community sector colleagues in leadership roles? And what can we learn from that? Together then, we want to come up with a plan. What are the opportunities? What could we do? What could we build upon that works? What's the potential? In the South East in particular, we're going to start with children's mental health because the surge is significant. We've got a lot of children and young people and parents and carers who need some help and support. If you can hold in the back of your mind that for some of our children, what we're looking for is someone they can talk to provide a non-stigmatising point of contact. If you can hold in your mind, if you are a child or young person with those protected characteristics, it's actually really hard to ask for help. What are our community infrastructure offers? What are our voluntary infrastructure offers that could really help with that? Providing different places, different types of support. If you could hold in your mind, what would your workforce needs be? Training, supervision, support? How might we grow the workforce together? Those would be the key things we'd really like to think about. In a minute, John's going to show us some really good examples of where we've done that, so what this can look like, physically look like, for us to consider together. I'm just going to pause there and check. Are there any immediate questions on anything I've just offered in that brief session there? Okay, I hope that's all made sense. So John, I'll pass over to you now to give us some of those examples. So what can this look like? Thanks, John.
Thanks, Andrea, and thanks, Richard. First of all, to say, obviously, a lot of you here today won't know about the organisation I lead, which is Response. And what I did want to say is sort of we have a number of partnerships, and we, if you like, have faced and overcome some of the issues that if you like, makes working with the third sector quite difficult. And we're more than happy to share any information that may help you work easier with third sector organisations going forward. So I'm talking about standard operation procedures, how we dealt with governance issues, risk issues, GDPR issues, things like that. We're more than happy to share with any organisation, be it statutory or third sector. So obviously, the organisation I lead is called Response. You want to go to the next slide, Rich, please. Historically, Response very much an adult charity. Our background is mostly in the provision of supported housing. We were in these sort of early days very Oxford centric. We provided supported housing for the individuals moving out of the Littlemore and Warnford hospitals. And if you like, we did that for many, many years. It wasn't until probably 7-8 years ago, we actually formed a partnership within adult services with Oxford Health and 5 other local charities to deliver what we believe is the first outcomes-based contract in the country. And that was truly a collaboration, truly a partnership. We have a partnership board, and we look at sort of all the system issues together and try and solve those as a group rather than individually. The whole aim of that partnership was to allow service users to, if you like, move between services when they needed to as easily as possible, and to ensure that they receive the right care in the right place at the right time. So that, as I say, that partnership is approaching its 7th year, and hopefully it will continue for many more years. As a result of that, setting up that partnership, we were approached by Oxford Health about what charities within Oxfordshire actually worked with and supported young people, because they were looking to their CAM service and were looking for options and models that might involve the third sector. And I spent a lot of time together with the director of CAMS at that point, going around Oxfordshire and trying to identify any organisation that was supporting children and young people. And if you look at the sort of the logos at the top, those are not all of the organisations, I have to say, but a number of the organisations that we came across who helped eventually to form what we call the CAMS Third Sector Partnership. And this is a statutory provision with Oxford Health. And what it involves is the placement of a CAMS worker within each of the charities. So they work with a caseload, and they're able to access Oxford Health's care note system. They receive support from Oxford Health. You know, if they're having some issues and are struggling to support any young person. So, if you go to the next slide, Richard, please. These are the areas, as I say, from not really providing children and young people services 5-6 years ago. These are some of the areas that we're involved in now because of those early day partnerships with Oxford Health. For the CAMS one, as I said, we have embedded workers in several charities across the county. The whole idea of that as well is that we have a non-clinical engagement method for young people. So some of the young people are actually being supported with their mental health through what their interest and hobby and pastimes are. If you look at one of the organisation tracks, it's motorcycle repair, mechanics, bicycle repair. But the individual working in those charities has received training from Oxford Health, so that they're assured that we're using an evidence-based intervention model, and then we're able to collect the efficacy of the model as well. We're also, I know we're not the only third sector organisation, but we are involved in the mental health schools delivery teams. We have a mixture of workers who are employed by Oxford Health and workers who are employed by Response, and indeed the operational leadership of those teams provided by Response as well. and the clinical leadership by Oxford Health. That service now is in its third year, and I believe to be functioning very, very well. When we're hopeful that we'll get some additional teams in the very near future. We also know that many organisations are involved in the delivery of IAPT, but that seems to be specific to certain areas, and it's not a sort of a national acceptance that the third sector actually can be involved and do deliver. And we know that, you know, within Oxfordshire Mind have a very, very significant delivery presence in IAPT. Single point of access, again, you know, there are many organisations that actually have workers embedded in single points of access with the whole sort of ethos that the third sector workers may have a better knowledge of what the community assets are in terms of charities, support groups, etc., and can actually help young people engage with services more local to them, who might support them and mean that they actually don't need to come into statutory CAMs. Embedded workers, this is probably one of the most common models that you will see across the country, where third sector workers are embedded within community teams, and indeed in many cases in inpatient teams. You know, where we were looking at some stuff with Oxford Health around their sort of tier 4 service, inpatient service, and how some local charities might actually be able to give time in terms of, you know, looking at the catering within those services, the actual what the young people do in there in terms of drama, music and art, to actually make sure that their experience is a lot better while they're in there. So it is sometimes just about thinking creatively about how the third sector might actually be able to improve services and support the staff that are working very hard in those services. Early intervention psychosis, we don't as an organisation have that relationship, but I know that some third sector organisations across the South East do help deliver early intervention psychosis services. One of the other things that has actually grown out of our relationship with statutory organisations and commissioners in Oxfordshire is a new service called the Mental Wealth Academy, which is a service directed at 16 to 25-year-olds. And that was the result of a government grant from the Department of Health and Social Care. Because of our involvement in statutory CAMs, they match funded us to work with and set up this service. And that is a partnership between ourselves and, get this right, 7 local organisations to work directly with 16 to 25-year-olds. That's in its second year now, and the model itself has been externally validated, and the results are actually very, very encouraging in terms of the feedback from young people about how effective the treatment is. And again, it is an evidence-based intervention model that we do actually analyse and research very, very carefully. So that service is getting a degree of interest from across the country, and it is a lift and shift model. You know, we're happy to talk to other areas around how they can maybe set it up. We're also just in the process of submitting a bid around the Thames Valley Complex Needs plans, and that's the new funding that's coming out to work with sort of the most complex young people across the Thames Valley, and that will be a statutory third sector partnership as well. Because as well as sort of having the clinical expertise, we realise that these young people will spend the majority of their time in their local community, and therefore to have a third sector support system close to them is going to be exceptionally valuable. The other thing, and probably an interesting one that we're involved in at the moment, is the career progression pilot with Oxford Health. As an organisation, we lose the majority of our workers to Oxford Health or local authority services. They work with us for a number of years, and then they will leave for positions within Oxford Health. A number will go on to do social work or to actually do nurse training. So we're actually trying to formalise that, if you like, that career pathway for them, where we recruit people on the basis that they will spend 2 years with us, will complete the care certificate, and then will have access to the associate nurse training with Oxford Health, therefore providing actually a pathway and a career to becoming a qualified nurse. And the thing that's interesting for us is we're able to access a potential employee group that maybe Oxford Health were not able to access. So these people that are coming to work for us, many of them, 19 and 20, would not have thought of a career in the NHS. But when they actually have the experience of working us, they actually say they would quite like to become qualified in the future. So we're just looking at how we can formalise that process, and we've recently just recognised as the first third sector accredited training centre for the care certificate. So that's the first step in the pathway, hopefully. Next slide, Richard. Probably teaching people to suck eggs a little bit here, but obviously for statutory organisation, the benefits of a close relationship with third sector organisations and partnerships is, you end up with better plans for individuals, both, clinical, medical plans, but also, more importantly, community and social care plans for people. There is more emphasis on community resources and actually accessing things closer to home. And as I said, regardless of the intensity provided by statutory organisations, young people will spend the majority of their time, within a 5-mile radius of their house. So it is important that we think about local organisations, and that doesn't mean the large charities like Response either. It means that local charities that are operating in your local environment. Workforce requirements. I think Andrea said it, we look at the demand, we look at what's coming on the horizon, what's here today, and we don't in isolation have the workforce to meet the demand. So we have to start thinking creatively about how we deliver services. And for me, that has to involve the third sector where at all possible. Recruitment pipeline I talked about. As I said, we lose most of our workers leave Response to work for statutory organisations. So it is just going to make that pipeline easier for statutory organisations. Agility and innovation, you do get that working with the third sector. Some of the smaller organisations are exceptionally innovative and exceptionally agile. And we've seen over the last 18 months where government funding in terms of COVID, it's come down, it needs to be spent quickly. You need to set services up exceptionally quickly. The third sector are very capable of doing that. Managing demand, as I said, that's, we know that we can't cope with the demand that's going to face us over the next 5 years. Value for money is, I think this represents the money that we receive through Oxfordshire CCG and Oxford Health in terms of the CAM service has probably been tripled by each organisation involved, because for every £1 we receive from the NHS, the reality is we will raise another £2 from large donors, institutions, grant-making bodies because of our involvement in NHS organisations. So it is money exceptionally well spent. And satisfaction, I think, you speak to community mental health workers, in particular clinicians who see young people within the charity environment, and the feedback from them is nearly always positive about how different it is to see people in an environment that's not clinical, and the discussions and the openness that sometimes that leads to. Next slide, please, Richard. Obviously, it's a two-way relationship for the voluntary and community sector services. There are many benefits of a close working relationship with statutory organisations. Again, for us as well, it delivers better outcomes. And the reason it delivers better outcomes is our staff have better access to training. I can't emphasise that enough, is that some of the training we receive from Oxford Health because of our partnerships is exceptional. And it results in greater job satisfaction for our workers as well. But obviously the outcomes are better. We're using evidence-based interventions and we're actually measuring the success of those as well. Workers within the third sector are more prepared to work with what you would call sort of higher risk individuals because of the supervision they receive, because of the support they receive with CAMS, and because of the joint risk management with CAMS clinicians. So they're more likely to work with people knowing that they have a reliable and quick access to support when they need it. Again, career pathways within the third sector it's very attractive to young people who maybe haven't, for many reasons, maybe they haven't done the A-levels, maybe they haven't been to college, but they come into work at the third sector at a much lower level sometimes, but they can actually see that they can progress within that system, and that gives them hope as well. Secure contracts, and this, I can't emphasize this enough. If you are working in or commissioning third sector organisations, please do think about the term of the contract, because the longer the term of the contract, the reality is the more the organisation is going to be invested in it. And as I said, it attracts additional funding for third sector organisations. We will use, say, every pound from the NHS or local authorities to try and match fund that from major donors. The other thing, just to mention from our perspective, and probably a lot of our partners, is that during COVID, our relationship with the health service has been invaluable. The support we received during COVID has been amazing. We were able to access PPE. We were able to access vaccines for our staff. We were able to access, health and safety information around the whole, COVID and cross-infection issues, which have been just great. And then finally, networking. When you work in partnerships, you actually begin to hear things, and you open your eyes to what other organisations are doing. And it leads to change within your own organisation. Next slide, please. And challenges, and this is just being honest. There are challenges when you work in partnership. Partnerships take time, and the NHS doesn't always make it easy to work in partnership because there are numerous hurdles that have to be got over in terms of governance, GDPR, safeguarding, risk, that NHS colleagues have to satisfy internally so that they can actually, agree a partnership model. As I said, those are some of the hurdles that we have overcome, and we're happy to share the information that we have. Obviously, values risk approach between the third sector and statutory organisations don't always align. And I think that we have to accept that from the beginning. Finances are a challenge, purely because some people see, the third sector as a cheap alternative. It's not, and it shouldn't be a cheap alternative. As I said, the value for money comes from the additional funding that organisations will bring in, not by providing sort of less paid workers or inferior working conditions. We should be contracting with the third sector on an equal basis where possible. And commissioners, my plea to all our commissioning colleagues here today. I think we're probably all involved in our community mental health transformation, our transformation plans, ICP plans, ICS plans. Everything and every white paper over the last 10 years has said that the third sector must be involved in the delivery of services. So the evidence is there, the evidence supports it. where people and you meet resistance around involvement in the third sector, the delivery of services, please point them to other areas of the country which work exceptionally well. New service design, any new service, any new pilot, the first consideration should be how can we use what's available in our local community to support the model that we're designing. And that only comes from the awareness of what's in your immediate environment. Now, I talk to commissioners from other areas and say, well, you're lucky in Oxford, you have this wealth of charities. And I said, well, you know, have you spent time actually finding out, you know, have you gone to your local infrastructure organisation, which every county in England has an infrastructure organisation. They will give you a list of every charity that works with young people. And again, you know, if I use responses experience, sometimes organisations that you wouldn't naturally look to work in CYP may actually be willing to become involved. You know, talk to organisations about what their capacity is, what are their plans as an organisation in terms of development. Would they be willing to work if you provided the training and the resources? Would they be willing to become involved? And I would suggest that most organisations will consider it very carefully. Support growth, and again, this comes back to funding. An organisation, third sector organisations, do have overheads, do have back office costs. So please just acknowledge them and look at acknowledge the sort of real cost recovery that organisations need to receive. Not just the salary for an embedded worker, but actually there will be, you know, back office functions that they need to do. The charity, any charity that sort of grows in terms of income, is also required to grow its reserves to manage the risk. So it is an acknowledgement that they're not putting the money in the bank for no reason. Actually, by law and by charity commission, they are required to build up their reserves if they build up their income, so that actually they manage the risk, because they're taking on greater risk. The more employees they take on, the more risk they're taking on in terms of redundancy. So please just acknowledge that what charity law is, what the Charity Commission recommends is good practice within that sector as well, and acknowledge that they're not trying to make a quick few pounds. They actually do have to ensure that their governance requirements are met as well. And I think that's it. I think I've probably gone on long enough.
John, thank you so much. That was a really rich presentation. You've packed a lot in there in terms of, you know, what works, what we need, what the risks are, etc., and the challenges are. There are some really good examples, John, in the chat that have emerged while you've been speaking of different examples of services, and some very clear statements about preferences for, look, can you give us a bit of kind of longer term funding, 5-year funding would really help. There's some very good questions from Marie that would be really helpful for us to pick up. So Marie's saying, John, do some of the people working with Response have lived experience of mental health conditions? So that's the first part of it. And the second part of it is the service actually providing a career route for children and young people to kind of enter into the workforce at a later stage?
So I think to answer the first question, a number of our employees do have lived experience. A number of our employees also don't choose to disclose that they have lived experience. It's not, it's not a requirement, but we are aware, and our HR department are aware of those who have lived experience. In terms of providing a career pathway, the answer is yes. We are involved at the moment in delivering the supported housing for 16 to 25-year-olds across Oxfordshire. And we as an organisation now have a commitment to provide apprenticeship opportunities within each of our departments, specifically aimed at the young people who are within that pathway. So we will be providing that. I think our first one starts or certainly Lee's on the call here. He may know a little bit more about it. I know we've advertised for it, so.
Yeah, it's just going out to advert, John. So we're employing 2 apprentices. Interesting, they're going to be we're trying to join up some of our services, so they're going to be positioned within our mental health support teams, so they've got a lot of colleagues and support around them, but they're going to be pulled from hopefully the YPSA contract that we've got somewhere else. So it's about trying to have that network within our own organisation. So yeah, we've got 2 that we're just about to advertise for.
And just to be clear, that that is every department response, from finance to HR to communications. Everyone has to create an opportunity for the young people at a bare minimum of work experience, so that young people can get a work reference. So that's what we're working on at the moment.
That's brilliant. Thank you so much, John. I can see some excellent examples. Thank you, colleagues from signposting the No Limits. Natalie, thank you. We're a big fan of No Limits innovation. So from the South Coast, excellent examples from Kent and Medway. So Sue has popped in the kind of 3-year framework that's been developed in Kent and Medway, which is, it's really significant. Great examples from the Sussex patch and many more. So please keep those coming. Any other kind of points to discuss with John, colleagues, while we've got John available, just to talk about how's that innovation worked and what's enabled that, and what have some of the details been? Anything else on that? Okay, I think you've stunned everybody into silence. Now I can see a hand. Go on. And Kenny.
Hi, can you hear me?
I can hear you. Go on, Ab.
Hi, thanks, Andrea and John. That was really helpful. And I know my colleague Kerry is on the call too. So we're from Surrey, and we have a new Surrey Alliance, where we're working with NHS, Surrey and Borders, Tavistock and Portman, and a consortium of voluntary sector organisations. And we're at the very early stages of a 10-year contract. So that's a completely new approach for Surrey in terms of a long-term investment in working with the voluntary sector and bringing different people together. It's got massive commitment from everybody to make it work. There's a real commitment to early intervention, as well as all of our clinical intervention colleagues and working together. So some of the themes that you picked up. And we're actively working through the challenges around the differences of approach, around risk and consent and data and digital. And I'll be happy to connect with John outside the meeting, but I wonder if John could give us a couple of headlines about how you've worked through that, because you mentioned it yourself that it was particularly challenging.
Yeah, it is particularly challenging. We're currently doing a little bit of consultancy work with even with human beings around their sort of the way they work with the third sector as well, and we're currently dealing with the governance demands of an NHS trust in a different area. But as I say, we're building that information so that we can share with other charities who work in the area. I guess for us, in terms of our experience with the partnership model, we were very clear in terms of the terms of reference at the start. The big thing is to look at how decision making is going to be made and how that works. What is the model? You go for it through Alliance, or you actually, is it a lead subcontract relationship that you're going to have with the NHS? And it's important to be upfront at the very start about which of those you're working with. Also, in terms of the way access to the NHS databases, we've got around that through honorary contracts for our staff. And you'll still come across regions where they say, "Oh, we can't do honorary contracts." It's complete and utter rubbish, because honorary contracts are standard in other areas, so it's not it's the same in NHS. So these people will put barriers up. They will find ways and reasons for not doing things, but if you look elsewhere, those things are already happening. So the honorary contract tends to get around a lot of the GDPR issues, as long as people have done the appropriate training. and are aware of what the governance issues are within the trust that they're working with, and they work to those. And as I say, then you just need to, at the very start, be very clear about the decision-making processes. And it's quite easy for current services. It becomes a bit more difficult when new money comes down, and you have to decide which of your partners are going to be providing the new services, because the third sector are a bit of a competitive lot. And we should acknowledge that, and if there's new services and new money, they will want to be involved, and it's how you deal with that. And you need to stipulate that at the start. The other thing is to do you allow new entrants into the partnership? You need to be clear that at the start. Do you allow sort of new organisations who do develop? How are you going to welcome them in, or indeed how are you going to exclude an existing partner? If you can get that all sort of agreed at the start, it's much easier. But a plea as well is to, when you set up partnerships, please do, if you like, make sure it doesn't turn into a monopoly, and that we actually look to some of the very, very small organisations that exist within our communities. And sometimes a small piece of funding can make an exceptional difference to those organisations. So make sure your partnership's not a monopoly, would be my plea as well. I don't know if that's helpful.
Thank you, John. If I can just come back. So there's a question about the 10-year framework. So there was a real shift in commissioning in Surrey, with the local authority working together with local CCGs to pool money in order to do that, and also a real shift in moving away from short-term funding for the voluntary sector to longer-term funding, and also a shift to looking at how we could all collaborate. So there's a lot of change that went on in the last sort of 3 or 4 years, and so this we've literally just started this contract. And I joined it in April, and actually I attended another meeting on similar collaborations, and my reflections would have been that we did spend time working out how we would work together, but actually I think if we had our time again, we could have put much more time into setting up the terms of reference for partnership working around equal partners, etc., as John mentioned. So that was a key piece. To really understanding the cultures, behaviours and attitudes differences on the sort of NHS approach and the voluntary sector approach, particularly people's attitudes to risk, information sharing and consent around that, how we learn and collaborate and how we challenge each other. So it would have been good to have had the time to do a really good piece of work on that, because that would have made bringing everything together when you're mobilising and delivering easier. And we're still stepping through some of that stuff.
Yeah.
And
the other thing
is information governance and digital and data, and the chasm that kind of exists between the voluntary sector and what is a very regulated, for completely understandable reasons, NHS sector. And we're having to step through these things as we are delivering, as we are reducing waiting lists. And so my plea to others is do these pieces of work early before you start delivering, because that would make things easier.
It's absolutely key, because the other thing that happens, unfortunately, is that key individuals who've been present at the start of partnerships move on, and you get a lot of trust built up in the original partnerships, and you have very senior people, CEOs of the charities, and if they move, new CEO, new director comes in and go, well, why did you agree that? That doesn't make sense to me. So if you have things written down and agreed at the start, it makes that transition with new staff much easier. That's my little bit of learning.
Thank you, John. So we've got lots of appetite here for sharing exemplar, where we've done the work on how do we manage IG and safeguarding and risk management and honorary contracts, etc. Let's pull together a little pack. We can certainly do that between us to share expertise. A couple more kind of points and questions. Lawrence, thank you, and Kerry for sharing the Surrey model. If we can share that at KSS meeting, that'd be amazing. Kerry, let's go to you next.
Yeah, hi everybody, lovely to see you John, one of the other things I'm interested in your experience is how you've helped the wider children's system recognise that actually a response to emotional health and wellbeing doesn't have to just come from a clinician, but actually can come there's value in the menu of intervention. Because I think that's some of the challenges that Anne and I will be facing as well. A lot of our conversations we're having at the moment, they're expecting a response from a clinician. We're not going down that road. But I'm just interested in how you've overcome that. Any key learning you can share, anything that can save us on our journey.
I think there's two things. One, you've got to ensure that the offer you're providing and the intervention you're providing, if it's non-clinical, is actually safe, and that it does deliver results. Because, you know, if you're persuading a parent, a carer, or someone, you know, from the local health system, we're going to refer this, or we're going to ask such and such to support them, you've got to be able to assure them that actually they know what they're doing. Which is why, you know, with our CYP services, they're evidence-based, the interventions, we have good supervision for our staff, and we actually measure the successes that we have. But I also go back to that, you know, where young people spend most of their time, no matter how intensive the clinical intervention, it's going to be 2 or 3 hours a week. You know, that if you're really intensive, 2 or 3 hours a week. So the other, however many, I don't know what it is, it's 140 odd hours a week, they're going to be at home, at school, or within a few miles of their house. So we need to ensure that they have some service, some support system that is not, you know, doesn't require them to travel to a local hospital, etc. And it is sometimes with, you know, when we set up the CAMS third sector partnership, we actually spent a lot of time with the director of CAMS, taking her out to meet the young people that were engaging with the charities. Because I think there was this belief that actually the third sector aren't working with, you know, complex young people. And when we visited them, we actually found out that, you know, 50% of the young people they were working with were also in CAMS, were receiving support from CAMS. But there was no communication between the charity and CAMS, none whatsoever. You know, and the third sector organisation weren't part of the CAMS care plan, and that was a consistent finding we had when we went out and spoke to organisations. Oh yeah, they're in CAMS, or they're waiting for CAMS, and you know that's a fairly consistent message. So, you know, a lot of. And we do have a waiting list, unfortunately, within statutory CAMS. Those young people are probably being supported elsewhere at the moment. So it is get them out, you know, take them out to visit places. That as a commissioner, you know, find out what, you know, organisation, and listen to the young people.
Thank you, John. So we're going to continue our conversation by moving to breakout groups on that listening to our children, our young people. Where do they feel safe? Where do they feel able to ask for help? What does that look like? Is key, and you'll see that thread in the chat. Lila, you've got your hand up. Did you want to say something before we move into breakout together?
Just the final Harry's going through in terms of the clinical bit. So what we did before setting up the contract care, we spent a lot of time with clinicians talking about governance and what John alluded to, make sure it's a safe service. So I think that's one of the sort of key discussions you definitely want to have around governance and how that's going to work.
Wonderful. So in that exemplar pack, let's look at a whole range, a suite of documentation that's likely very helpful. It's not to negate anything you're doing locally, it's just a supplement. So we will pull that together as a team and make that available online for everyone. Richard, I think by the wonder of modern technology, we are somehow or another going to make it into breakout rooms, and you're kind of in charge of this bit. Thank you. We've got some kind of specific questions to discuss together in smaller groups. for all of us to consider. So Richard, if you don't mind enabling us to move from here to where we need to be, that would be amazing. Thank you.
Thanks, Andrea. I'll push the button now. In around 10 seconds, you'll all disperse neatly. Thank you.
Everybody, thank you so much for the amazing contributions in each of those small group discussions. Certainly in the group that I was in, we had offers of, we could adapt our offer, we could change what we're doing to meet some of this pressure on children's mental health, which is just amazing. Thank you so much, and we will come back to every single one of you that said, we think we could help in this way, or we're happy to help talk about how we could support eating disorders or the pressure on children and young people in the community, etc. That's just amazing. Thank you so much. Where we have identified together that we've got providers in our voluntary and community infrastructure who are meeting the kind of gap in need that our commissioners in the same locality have identified. We had a brilliant example of that in our group right from the offing. We will put you together with your permission, if you don't mind, so that you can get to know each other if you haven't had the chance to do that already, and start to say, okay, so what could this look like between us? There's a great deal more we could be doing, and certainly the exemplar resources, certainly that this has worked for us, we've tried it, here's an example you can use. Please do send those things through to us as the regional team, and we will coordinate that and then send it back to you as a package. Where we've had additional offers of particular support, Marie, your offer around particularly the kind of funding, investment and training support, we'll very much be sharing that. For colleagues who got cut off, so Felicity from the Isle of Wight and other colleagues who are mid-sentence, please don't hesitate to post what you'd like to say or the questions you'd like to ask into the chat, and we'll pick them up retrospectively as a frequently asked questions. I hope today has felt really valuable, John, and from our perspective it's been a real privilege, I think, hasn't it, together to sit with you all. Thank you for making the time to be here. We'd really appreciate knowing from you all if this was a valuable conversation, which we can see it has been for many. Would you like us to convene another conversation like this in a few months' time that starts to look at other aspects of joint collaboration across our sectors? If you think that would be helpful, please do just pop something in the chat or talk to us about that. We'd really appreciate it. John, go on.
Just quickly, Andrea, and yeah, just echo everything you said. The question we were asked, or we focused on within our group, was around the CYP IAP training. And I think, you know, there was a number of people, myself included, who are involved in CYP services, and we weren't entirely clear what the difference between adults IAP and CYP IAP training was, and why there was such a disparity between the number of third sector organisations involved in adult IAP and the lack of third sector organisations involved in CYP IAP. So maybe that sort of differentiation and circulation to the group would be a useful starting point. But I think again there was that consistent theme that from the third sector organisations, we're happy to look at being involved in that and eating disorder services, but we need training. We need the resources, and then some interesting feedback from various commissioners around sort of, there was mention around IAP funding in terms of the train to recruit model, where people can offer training placements but actually couldn't promise the employment at the end of it. So some sort of partnership around that training around IAP was discussed. But yeah, there's some really interesting observations, but that was a key one for me.
Thank you so much, John. That's really important. So we'll work with HE colleagues and get that distinction clarified and out to you all. And we'll look at those points that you've raised as part of the next steps from this conversation. Donna, your hand's also up.
I am, thank you, Andrea. I just wanted to ask about eating disorders. A question I've asked locally, and I don't think we've really got to the bottom of it, is out of those young people that are now approaching, requiring Tier 4, have we missed an opportunity earlier on in their care? because I understand the focus on really supporting the children in crisis, but I'm thinking about those children that may be on that journey to tier 4, and actually what can we be doing more at a universal level. And I don't know if you've extracted any of that out, any of the children that have been supported, or if not, could we? So then us in public health and universal provision can try and stop the tap in a way.
Indeed, it's a spot-on question, Donna. So in terms of the eating disorder analysis of the child population, part of the report and recommendations highlights where the preventative offer could be strengthened. So we'll send that to you if that hasn't reached your desk yet. I apologise if that's the case. So you can see that. The other bit we're doing at the moment, Donna, that Lila is leading on our behalf with partners in this room is we've noticed a number of those children who are very poorly have appeared literally out of nowhere. They've had no contact with universal services as far as we can determine before they present as very ill. So we're describing it as a hidden children analysis, and we're asking a series of questions on those children. And that analysis, I think Lila went out today and completes the 24th of September South East wide, and will answer some of the questions you're just asking there. So that's the other thing to be really mindful of, if that's helpful.
Yeah, so if those could be shared, certainly the first document, it hasn't touched my inbox yet, but also that analysis, because then it's that wider system then, is it? It's how we can all support each other.
Yeah, absolutely. So we'll make sure that lands on your desk on that, and we'll send that around to everybody just for completeness. Thank you. All right, everyone. I think we could talk for hours because there's so much we could be saying and such a rich dialogue. Thank you. That's been possible because of your contributions today. We're so grateful. We will send around all the things we've promised. Some will be quite quick. Some will take a bit longer. If you can help us out by going, this is brilliant, please use this. We're happy to share it. We'd love that. That makes it so much easier. And we will be back in touch about meeting again together in a few months' time to then progress the kind of partnership conversation more broadly on other areas. Thank you so much and take care, everyone.